What do we expect their stool to look like? Hmm? It's formed, so it has this frothy, greasy-like color. It's called steatorrhea. They'll be frothy, greasy, they float. Over time, these patients may have rectal prolapse because it's so hard to go to the bathroom. These stools are large. Cystic fibrosis affects the skin, like your classmate was saying. So they have excessive amount of loss of sodium chloride through their skin. So moms may kiss their babies and say they taste salty. And so that's an indication that, hey, we need further work done. These patients also are more at risk for hyponatremia because they're losing so much sodium chloride through the skin. Growth and development will be delayed, and this is because of nutritional deficits and delayed bone growth. So these patients are at risk for failure to thrive, osteopenia, osteoporosis, and bone fractures. How it affects the reproductive system, puberty will be delayed in teens. Males, they'll be born without, they could possibly be born without vas deferens. They will have a decreased sperm count and or infertility. And females with cystic fibrosis may have thickened vaginal secretions, decreased cervical secretions, and difficulty with conception. Chronic pain may be anything related to like a headache or the pain you get from sinusitis or the work of breathing, using those accessory muscles and coughing. So they can deal with pain as well. And let us not forget about mental health. These patients may deal with anxiety and depression because of this diagnosis. So this chart, we pretty much hit every body system, but this slide breaks it down to early and late symptoms. So that's what I was saying. So you'll still have some pulmonary manifestations, but late. Barrel chest happens over time. Clubbing happens over time from this increased O2 demand. Yes, you have a question?
Is it always fatal?
Is it always fatal? It depends on the involvement of the organ systems. So if the respiratory system is heavily involved, yes. I was reading an article because prior to teaching this, I thought cystic fibrosis was something you knew at birth that you had, but there was this testimonial of a guy who was having a workup for infertility, and he also always had sinus infections, and I think like asthma flare-ups. So he was going to different specialists for all that, and one doctor tied or connected the dots and had him work up. He was in like his 30s. But see, his symptoms were not as obvious as like respiratory, like he wasn't having pneumonia or COPD or emphysema. He was infertile, which he didn't find out till after he got married, and him and his wife were trying to conceive. And who would think sinus infections, getting those all the time, would be an indication of cystic fibrosis? So that's just so some of these, because there's so many mutations, they may be subtle signs and symptoms that you just overlook, or they can be more overt. It's so many mutations. So like we said, 98% of those infants who have a meconium ileus at birth, they will be diagnosed with CF. So this is just a picture of what clubbing looks like. So how is it diagnosed? So early detection is key because the earlier we find out what's going on, we can help to prevent like different growth and development issues. They have a better chance of preventing like complications like failure to thrive. And research has shown that those children who get care earlier in life have better nutrition, better health than those who are diagnosed later. So there's genetic testing available. So if an individual or their partner has a personal history or family history, they should have genetic testing done for cystic fibrosis. And you can also test with amniocentesis in utero for some of the mutations to see. But diagnosis is usually made during the newborn screening.
During the newborn
Screening? You know how they do the heel stick and they get a series of labs. CF is a part of that. What they're looking for is elevated pancreatic enzyme called immunoreactive tricinogen, IRT for short. Normally our blood has only small amounts of this, but in someone with cystic fibrosis, it's going to be elevated. So they'll get that blood sample, and then they can also, if it's elevated, they'll confirm it by running a second IRT. And then they'll do DNA analysis. That's also a blood test if the second IRT is elevated. Now that varies from state to state, and I don't know what Louisiana, I have to look that up to see what they do. Some states get 2 elevated IRTs and then do a DNA analysis, while others just do 1 IRT. If it's elevated, then they confirm it with the DNA analysis. So it just varies by state. So those 2 tests are positive. What happens next? Is that it? What? You look like you know.
I don't.
Oh, okay.
I just figured that they had to do more testing.
They do.
Just that.
So the gold standard is the sweat chloride test. And that's a picture of on the screen. So the healthcare provider will trigger sweating on a small patch of paper that they either place on the child's arm or, if they're being diagnosed at a later stage, arm or leg. It's a TENS-like unit, TENS. And what it does is it delivers a chemical and also electrical stimulation. So it makes the sweat glands react. The paper absorbs the sweat and then it's analyzed for the sodium chloride content, the chloride concentration of it. And so that's how it's officially diagnosed. These are done at outpatient facilities, like your standard hospital does not do this. So a chloride concentration of 60 milliequivalents per liter or higher is diagnostic for CF in all age groups. Other tests that might be helpful with CF is your chest x-rays. So we'll see to what extent are the lungs involved. That helps us to see atelectasis, obstructive emphysema, things like that. These patients may have lung function tests done. Helps to measure the lungs' ability to exchange oxygen and CO2. Sputum cultures, that's going to be helpful in treating infection of the lungs if it's present. And some facilities even analyze the patient's stool. And what they are looking for there is the fat content, because it's not being broken down. So it's going to be present in their stool. And also for the presence of that enzyme, that trypsin. So what's our goal? So this is a progressive disease. It's incurable, okay? Our therapy should focus on maintaining the respiratory function as much as we can, managing infections, and promoting optimal nutrition. These goals should be mutually agreed upon by the patient as well as the nurse. So how do we prevent infection? We educate them about hand hygiene. If they have these central lines or PIC lines, they need to know how to take care of those, change dressings, how to handle those properly. And they should avoid other patients with cystic fibrosis. I know that's odd, huh? Well, you don't want them passing infection from one to the other. So if you're taking care of a patient, they should not be roomed together. They are in private rooms.
And we wouldn't be able to take care of 2 cystic fibrosis patients at a time, or no?
I wouldn't think so. Airway clearance and effective breathing with the use of certain medications, huffing and coughing. We'll get into that on a later slide. We want to maintain optimal nutrition. So these patients have a high caloric demand. And so sometimes they can't just get it by eating foods. They may have to have an NG tube placed or even surgical placement of a G tube to have like additional bolus tube feedings just so that they can meet the demand. And we want to encourage physical activity. Why? They have this respiratory issue.
So
We want them,
their lungs aren't just sitting there; they're actually expanding them and using them.
right, because aerobic exercise helps with loosening mucus, helping your, like she said, helping your lungs to expand, and it also prevents osteoporosis, those weight-bearing exercises and activities. But keep in mind, like we said before, these patients are at risk for dehydration. So even though we're wanting them to be active, they need to be taught signs and symptoms, like of what dehydration looks like and what to do if it occurs. So even if they're not as active as we like them to be, even months with this excessive heat, these patients should be drinking more fluids and even eating more salt or adding it to their food. So you teach your patients that it's okay to add salt to their food, even children, and promote like salty snacks too to supplement. So that's things like chips, pickles, pretzels to help. This is no longer considered it used to be considered a fatal disease of childhood, but now these patients are living longer because of the advanced treatment. So they should be focused on goals, getting married or having long-term relationships, getting careers and things like that. Going off to college if that's what they choose to do. And like we said, pulmonary involvement ultimately determines the outcome. And then the organ transplant can extend their life. So some may need liver, pancreas, lung, it just depends on how it's involved, how that organ system is involved. All right, so in your PEDS book, page 509 and 510, they have it broken down into therapeutic management, pharmacological treatment, and non-pharmacological. So you can imagine cystic fibrosis requires a multidisciplinary approach. We have doctors, nurses involved, nutritionists, respiratory therapists, physical therapy. They all are going to help us assist in taking care of this patient. So they're given bronchodilators, and that's going to improve mucus clearance. Mucolytics break up mucus. Antibiotics and antifungals are going to treat infections. So these can be oral, IV, or inhaled. So it is not uncommon for them to be placed on long courses of antibiotics. There are medications called CFTR modulators. What do those do? Just from the name, we told you that this is I told you that this is a disease of the CFTR protein. So what would that modulator
couldn't do it
More or give you some?
Yeah, so it helps their protein work how it's supposed to. Yep. It's not effective for everybody because of all the mutations, but they will try and then see if it gets better. So it helps that protein to allow the appropriate amount of salt in it and water in the cells. Anti-inflammatory, self-explanatory for the lung, the airway inflammation that these patients have. Pancreatic enzymes, those are given with each meal and also with snacks before they eat. And that's going to assist with digestion of nutrients. These patients will also have to have supplemental vitamins, A, B, E, and K, because those are your fat soluble and they can't digest fat. So they have a water soluble form just for CF patients. They also might have to be
vitamins one more time.
A, B, E, and K, your fat soluble diet, because these patients can't break down fats.
You said B or D?
D as in dog. Also, they may have to have calcium, vitamin D, iron, and zinc supplements. Laxatives or stool softeners for constipation. And if we have to treat their diabetes, it'll either be oral agents or insulin. But managing diabetes in these patients can be challenging. They have to have high calories or high intake, and we're trying to give them insulin. So it can be a fine line to tread, trying to balance that out, because they need more, but then their insulin requirements may also increase. Vitamin D and calcium for bone health, and some surgical interventions, like they may have their nasal polyps removed, or endoscopic procedures to remove, or lavages to remove the sputum and mucus out of the lungs, or the surgery for a G-tube placement. And then, of course, if they have to have a transplant organ, that's going to require surgery. They should get all their vaccines. Childhood immunization should be up to date, and flu, because we don't want these patients to get sick. Non-pharmacological management, coughing and huffing. So these patients should never suppress their natural urge to cough. We want them to cough and get that sputum out. Huffing is when they take a deep breath for 2 to 3 seconds and then forcibly and slowly exhale. What that does is it moves that mucus forward so they can cough it out. And I'll show you a video of that. CPT, that's the chest physiotherapy and posterior drainage. When done, that should be before meals, because that coughing and vibration can cause them to what? Vomit. Pulmonary function tests are done periodically, usually every 6 months. And pulmonary rehab is like your exercise training that we talked about, teaching these patients how to conserve their energy and different breathing strategies. Emotional support, once again, they may have anxiety and depression, and you may be the only one to notice that, what's going on. Nutritional counseling, they may have to be referred to a dietitian or nutritionist, because they need a high calorie, high protein, high fat diet. 3 meals a day, snacks in between. It may even require supplements. All right, I got a quick video for you all to watch.
My name is John Palmer, and this is Cystic Fibrosis Mind Way. I'm 15 years old, and have been treated for CF at Children's Hospital for as long as I can remember. But it doesn't get in my way. I just make it part of my day. When I grow up, I'll play basketball for the Cleveland Cavaliers. It's an exciting team, and maybe play with Kyrie Irving. He's number 2 on the team. If I want to play basketball professionally, I need to make sure I do my therapy, my nebulizer, and my huff coughs every day. 2 times a day when I'm healthy, and up to 4 times a day when I'm sick. First, I take 2 puffs of the inhaler. This opens up my airway. Then I hook the machine up. I put the vest on the clamp and then I buckle it. Then I make sure the holes are inside the vest. After that, you have to put your tubes in. Then I put the medicine in the nebulizer. Next, I turn the nebulizer and vest on for 20 minutes. My pressure is 7, and my frequency is 11. That's how fast it goes. But every kid has a different setting. Just make sure you know what your doctor told you to do. Sometimes the treatment takes longer if there's more medicine to do. After 10 minutes, I do my huff calls. When I'm wearing the vests, I get to play with my computer, play with my phone, or do anything I want for the time being until my vest is done. After 10 more minutes, I have to do another huff call. After I'm done, I take my flow vent and my nasal spray. If any mucus comes up, then I spit it out, and then I'm done. Then I get to have fun and play ball.
So you see, that's pretty intense, even for an adult. That's a lot to do, and he's a young child. So he should be, not should be, but, focused on playing and just enjoying life, and he has to do that. But imagine if you have a smaller child that's not as independent as he is, and you have 2 or 3 other children that you have to see about. That can be a lot for parents and the child as well. So I just wanted to show you. And you see, you notice, huh? Yes. And you see how he said 2 times when he's well, or 4 when he's sick. So it increases if they're ill, have an acute illness, their therapy increases. That would be a lot for me to try to keep up with it and do. So.
One of my best friends has a little boy, has cystic fibrosis, and he's like 4. And they've been doing treatment like the CPT. He has a vest. He does breathing treatments. He has pancreatic enzymes that he has to have before he eats, and that's their biggest thing right now. He's good with all his other therapy, takes all his other medicines, but like he'll say I'm hungry, but then if he doesn't eat and he takes the pancreatic enzymes, he has to eat.
Right.
But if he's hungry and, so it's like, that's the biggest thing is trying to get to see if like he's going to eat, if he's not going to eat.
Oh,
So
because he says he's hungry, then he may not eat it.
Right.
I
So
see what
they're
you're
like,
saying.
they wait to see if he's actually going to like
That's
eat
challenging.
something. Yeah, that's the most challenging thing at the moment. But
And then they have to bring that everywhere.
Yep.
They have to bring that medication because it's not just at home. It's easy to do things if you're at home, but going out to restaurants and eating or family functions, having to make sure you have all your things.
And it's like the little, it's like little beads, and you have to open them all.
And sprinkle it on.
She sprinkles it on a spoon of applesauce.
Mm-hmm.
It's a lot.
It is. It is. So these patients, thank you for sharing that. They may require frequent hospitalizations, so it is very important for the nurse to use this time to review like old and new information with the patient. So remember we said that they have this thick, sticky mucus. Well, in times of illness and infection, it's going to be even worse, okay, because of the obstruction and just the immune system and how it works. Most of these patients with infections involve Pseudomonas, MRSA, and yeast are the more common bacteria that you see. So as the nurse, we are to get a comprehensive physical exam, including vital signs, but focused assessment is on that respiratory system, okay? We're asking the patient, the cough that you have now, is this your baseline or is this worse? You know, what does the sputum look like? We're auscultating the lungs, wheezes, crackles. Taking note of any cyanosis, clubbing. What position is the child or the adult in? Are they in a tripod position because they're not moving air? Of course, we're going to get their O2 saturation. We're going to ask about their diet, their appetite. Are their treatment regimens, like their coughing, their huffing, their CPT, has it been effective? Are they using their vest? Asking about any chest pain from coughing or abdominal bloating, and what do their stools look like? So that's all involved in the assessment process. And then as the nurse interventions, we're going to give those prescribed medications, perform CPT, and administer humidified O2 if needed. Proper dental hygiene is important because their sputum may be foul tasting and have an odor, so we want to make sure that they're doing it right and frequently, and we may have to do it too for them. Good overall nutrition, so these patients need twice the amount of daily calories. So they may have to add more cheeses to their diet, peanut butter, whole milk, eggs, to get what they need. In infants, they may need concentrated formula, okay? And if they're breastfeeding, the formula can be added to the breast milk so that they get the nutrients that they need. Education. Doing periodic health assessment, this is going to monitor for any growth and development delays. This is where you're going to catch it. So plotting their growth on those growth charts, getting those routine immunizations. We want to encourage age-appropriate activity. So they should be as active as they can. There are no limits, only just individualized, you know, what that patient can do. So they should be attending school, participating in sports, just like he said on the video. With infants, we need to educate the parents. So that stool that they have, the steatorrhea, because of the high content of fat, is going to be irritating to the skin. So think about diapers. They shouldn't let the bowel movement stay on the babies for an extended period of time. They should be changing their diapers frequently and assessing for any skin breakdown. Not only do these patients deal with anxiety and depression, but think about body image disturbances. So if they have the clubbing or the barrel chest, you know, they look different than their peers. If their stool has an odor, that's steatorrhea. Think of how embarrassing that might be. You go over to a friend's house, or teenagers, and they're having sleepovers, you know, things like that. So just kind of try to put it real world, you know, not just textbook, but like if that were you or your child. So the family may need support too. Parents may feel guilty because it's a recessive trait. So they got the gene from each parent. So they may feel guilty that they caused this for their child. financial support because of all the medications, frequent hospitalizations that have to occur. So lifespan considerations. So for teens, you want them to be independent, but at the same time, you want them to know what they're doing, why they're taking it. It shouldn't be parents just know at a certain stage they should be in control of their self-care. The parents shouldn't just know their regimen. They should know why they're taking the medicines, how long their treatment should be. They are at risk for fractures. They're going to have delayed puberty, about 18 to 24 months after their peers. And some girls may not have menstrual cycles. For adults, males, because of their absence of vas deferens, may be infertile or have a decreased sperm count. But that does not mean that they can't have normal sexual relationships. So they're infertile, but they're not impotent. So they're not dealing with erectile dysfunction. They just may not be able to conceive children. And females, the same thing. They may have difficulty with conception. But also, if they are able to bear children, you want to make sure that they're aware that this gene can be transmitted and carried to their child. Also, think about the high demand it puts on the mother's respiratory system while she's pregnant.
Yeah, it has to be from both parents. So if,
Mhm.
say, for example, she has the gene, or she has a baby with somebody else that doesn't, the kid's not going to get it because she only had it.
But how do you know unless you do that genetic testing
So
before?
if she has it, like if they both have it, like they have a history of it,
Mhm.
say she doesn't have it but she has the gene, if she, like whoever, he or she would have to go get the gene testing to
Mhm.
find out if they're,
If
and if then they're both are matched, then the kid's gonna have it, for sure.
well, one of those 4 births will have it.
Oh,
Yeah, so, yeah. Doesn't mean that each child will get it. And also there's a higher risk of premature infants in mothers with cystic fibrosis. So just making sure that your patient is aware of all that. So long-term damage to the pancreas, the liver, and the lungs may require organ transplant, and then those other surgeries we talked about for bowel function, sinuses. And then this picture just kind of puts it all together of how cystic fibrosis affects the body. Any questions? Moving on to PKU, phenylketonuria. I have this. I'm going to say PKU here on out. So this is an autosomal recessive inherited disorder involving amino acid metabolism. So what happens is these patients don't have this gene, phenylalanine hydroxylase. They don't have it, or there's a defect in it, okay? Let me say, not that they don't have it. There's a deficiency, so there's a defect. This gene is responsible for converting phenylalanine to tyrosine. So when there's an accumulation of phenylalanine in the blood, it can result in irreversible brain damage, seizure disorder, and intellectual disability. Okay? So these babies may appear totally normal at birth. They may only have a slightly lighter complexion to their unaffected siblings. The damage can start within weeks after the baby starts drinking breast milk or formula. Why? Yes. He said because it's high in phenolphthalein, and that's right. So that's when you notice it. If diagnosis is delayed, it can lead to signs and symptoms like a mousy or like musty odor, body odor, and urine. Intellectual disabilities, microcephaly, growth retardation. It's more common in fair, blonde, blue-eyed infants of Irish, Scottish, and Polish descent. So it's mandatory screening, so diagnostic evaluation. All 50 states mandate that newborns be screened for this. The screening is not performed before 48 hours of birth because that can yield false negative results. And the infant must have been, the infant should be ingesting breast milk or formula for 24 hours prior to testing. So it's not done any sooner than 48 hours after birth, because that's going to yield false negative results. And the infant should have at least been ingesting milk, breast milk or formula for 24 hours. So some instance babies may be born and they have to be NPO, or they might have other things going on. We're not feeding them, we're holding off on feeding them. So 24 hours after feeding has begun, that's when they can be tested. Because it's inadequate. What are we checking for? Elevated phenylalanine. If they haven't had it, how will we know?
And they would know in the hospital before they left.
Yes, but ideally. But vaginal birth, sometimes they just stay 24 hours and they're gone. So they should follow back up and have this screening done. So it may not occur in the hospital setting, depending on discharge and things like that, but they should be brought back. That's very important. Because if their mom is discharged early, you can't keep her because of that,
No, I'm saying, but like they would know relatively, like at their first week checkup or.
Yeah, with the testing, and then further testing is done. So this is a screening. So this alerts us that, hey, it's a possibility, but there are other confirmatory tests that are done. So if the screening test is elevated, then they have repeated serum tests that are done to confirm. Just like with CF, PKU, early detection is very important in order to minimize the mental disability that's associated with this disorder. As the nurse, our role is mainly education and being supportive. Because the treatment is a rigid and strict diet, or in infants, a specialized formula. So they may need referral to a registered dietitian. These foods can be very expensive, so they may need financial support resources. And if the parents of an affected child want to become pregnant again, they need to see they need to have genetic counseling, or if your patient is an adolescent, they should have genetic counseling. So the special formulas that these patients are treated with, they are low in phenylalanine. And then if they're taking food by mouth, the diet should consist of vegetables, fruits, starches, cereals, breads. Those are okay. But like the chart says, no meats, no dairy products, no dry beans, nuts, or eggs.
So it's basically like no protein.
Exactly. You cannot eliminate completely. It's in everything, but what we're trying to do is minimize the ingestion of it.
Sorry, that was no meat, dairy, beans.
Nuts, eggs. They do have a drug, sapropterin, that's given, but it's not effective for every patient with PKU. So usually it's a trial and error. They may prescribe it, check levels, and if it's not working, then they take you off. But it comes in a tablet or powder form. So that's fairly new drug that the FDA has approved, and what it does is it helps the body break down the phenylalanine. This word right here.
They're
That's the
basically
drug.
vegans from birth.
Huh?
They're basically vegans from birth.
Unfortunately. Well, I don't know. Can vegans eat bread and all?
They just eat incomplete proteins.
Yeah.
You said that's the drug that they give them?
That can be used to treat. It's not effective for everyone. It's mainly that strict and rigid diet. So that's just a picture. So of some of the food that they have to. And that's it, y'all, on PKU. That's it in a nutshell.
Can they grow out of it? No.
No, lifelong.
I think my friend her baby has PKU.
You think
And
so?
yeah, because, well, I remember them telling me, like, oh, she can't ingest protein, so they don't give her any protein. And she won't be meat or stuff like that. They were like, she's going to be basically on a vegan, not vegan, but like vegetarian diet. So I think she doesn't like it.
So, what happens if they eat something they're not supposed to?
So
It's,
the buildup of phenylalanine happens because they can't break it down.
like, even one little thing, and then it throws them into,
No, but accumulation of it. Yeah. I mean, if they do something one time, I wouldn't imagine that would just throw them into, but it could if it's enough.
Is there like a rescue type thing that can happen? Like if they accidentally eat this like over with whatever, like the way you get like an EpiPen if you're having
Oh,
or something.
No, that's a good question. Nope, not yet. Maybe somebody will come up with something. Any questions on PKU? All right. This person's on 9:50. Okay, y'all can take a 5-minute break, and then we'll get into thyroid. So let's start with basic A&P of the thyroid. So it's a butterfly-shaped organ that's in the middle of your neck, and it's responsible for secreting or producing 2 thyroid hormones, T3 and T4, right? Right. The main function of T3 and T4 is metabolism. So regulate how our body uses energy. It also controls growth and tissue differentiation, helps regulate body temperature, heart rate, weight gain, weight loss. So another quick review, the regulation of the release of the thyroid hormones is done by the anterior pituitary gland. So it releases TSH, which is thyroid stimulating hormone, and a negative feedback loop. So what that means is when T3 and T4 are low, more TSH is going to be released. When T3 and T4 are high, less TSH is going to be released. Thyroid is also responsible for secreting calcitonin, which helps us regulate helps maintain the blood calcium in our levels. So just remember all that. That's going to be helpful going forward. All right. So diagnostic evaluation, it is mandatory. This is also included in your newborn screen. Screening for congenital hypothyroidism or hypothyroid disease, period. So labs that we look at. So this slide, I want to make note, it's different. I added like the normal values. You see that, T3, T4, TSH? So I added the value range. You don't have that on your handout that I posted to Candace. So labs that we often look at are T4, T3, and TSH. We also look at anti-thyroid antibodies. That's going to let us know if there's an autoimmune process that's occurring. So what we expect to see in hypothyroidism is a high TSH. T3, T4 is going to be low. In hyper, we're going to see a low TSH and a high T3 and T4. Important to note though, with congenital hypothyroidism, you may see a normal T3. So T4 may be low, but T3 may be normal. And that's because oftentimes it's the last thyroid hormone to be affected. So you do this right after they're born, and it may still be normal, but eventually it will become low. Okay? We do thyroid scans and ultrasounds to check the position of the thyroid gland, also to identify any nodules or tumors that may be on the gland. Also for Graves' disease, they give radioactive iodine, and then they scan the thyroid gland too to see if there's a high uptake of, and that's how Graves' disease. So a scan may be done just to check for nodules or tumors, or it may be diagnostic for Graves' disease. X-rays are helpful in determining bone age of individuals and also growth charts. So this will help us identify any disparities between the height and weight of patients. Hypothyroidism is a disorder in which active levels of the thyroid hormone are decreased. It's twice as common in females than it is in males. More prevalent in white than black patients, or individuals, I should say. But then more prevalent in Hispanic, Asian, and Native Americans than white. It can be congenital or acquired, so they can be born with this, or something can happen later in life and they can develop hypothyroidism. And we'll differentiate between the two in a later slide. So a rare, but can happen, complication of hypothyroidism is myxedema coma. Anybody know what that is?
It's when their levels get really, really low.
Yes.
And they go into a coma and their temperature is really low.
Yes.
Confused.
Yes. So it's rare, but it's very serious and life-threatening crisis. So it can result from hypothyroidism that's untreated or undiagnosed, they may not even be aware, or they're not taking their medicine, or maybe they can't afford it. TSH levels are going to be critically high, and T3 and T4 are going to be so low they may be undetectable. Okay? It can also be precipitated by infection or trauma. And these patients are going to have signs and symptoms, non-pitting edema. Okay, so they're going to be edematous, but it's not going to pit. Severe edema of the face and the tongue. Metabolic disturbances. So they're going to be hypoglycemic hypothermia, everything low. And it, like she said, if it's not properly treated, it can result in coma, then death. All right. So that, as you can imagine, treatment is going to occur in a critical care setting, and they may need cardiovascular pulmonary support, and T4 may even need to be given intravenously. All right, so congenital hypothyroidism can be caused by a number of genetic problems. There could be hypoplasia or absence of the thyroid gland completely, or iodine deficiency. So those are contributing, those are most of your common causes for congenital hypothyroidism. Most of the time in these babies, you may not notice anything. They might not have any of these signs and symptoms that's listed on this slide. But if they are symptomatic, you'll see jaundice, a thick tongue, poor feeding, a hoarse cry. They may even have a goiter, bradycardia, dry skin, and they won't be gaining weight. How do y'all think we're gonna treat it? Huh? Yeah, you know what the name of it is? Synthroid. Levothyroxine. They're gonna take it and then maybe be tapered off or weaned off later on. Huh?
Don't they need it throughout their life?
That's right. It's lifelong treatment. It's not something that will get better and they stop. And think about as the child grows, they're also going to need adjustments in their dosage. It won't be the same dosage throughout their whole life. So yeah, they will lifelong treatment with Synthroid or levothyroxine. So acquired hypothyroidism, it can be caused from an autoimmune response, and so the most common, which this is the most common cause, autoimmune thyroiditis. It's also known as Hashimoto's. Other causes, the thyroid gland can just have atrophy from aging. What else can cause hypothyroidism? They weren't born with it. Radiation. What else with radiation?
Cancer.
Or a treatment. Radiation or surgery? If you remove someone's thyroid gland, it's going to cause them. You fix the one problem, but you cause it another. Essentially, if they have a thyroidectomy, they can have acquired hypothyroidism.
They have some kind of on it, and they just remove the nodule or remove the thing from it.
I guess it depends positioning and size and all that involved. So that's not a yes or no.
It depends on if it's making more thyroid or less.
Yep. So it depends. What about lithium? Lithium can cause someone to have hypothyroidism. It interferes with the synthesis of thyroid hormone. Also, some patients, they take medicine for their hyperthyroidism, what causes them, so anti-thyroid medications, and we'll get into that more too. But like she said, radiation and just loss of that tissue from surgery too. And children and adults, hypothyroidism usually presents with extreme fatigue. They don't even have the energy to do their daily routine. Other signs and symptoms, decreased appetite. So think about it, everything's low. They have sensitivity to cold, hypothermia, bradycardia, constipation. They don't have those thyroid hormones that they need. Thin hair loss. What's unique to children is that you may see them gaining weight but not getting taller. They may have delayed puberty too because of hypothyroidism. And school-age children, you may see a decline in their school performance. Not that they're being lazy and they don't want to do it, but they have a medical reason as to why. So if this goes untreated, it can develop into irreversible intellectual disabilities. That's why it's very important to start placement as soon as possible in these infants, if it's congenital, okay? And like we said, the replacement is going to be the levothyroxine. Nursing management also includes following growth charts. That's how we're going to detect those delays and disparities between their height and their weight. We're also checking for milestones. Are they slow with their developmental milestone reaching those? Could it be because of hypothyroidism? You want to educate the patient, the parents, if it's a small child or infant or small children, that this medication is to be taken the same time every day, and that's usually morning time. Okay, we don't want to miss any doses or double up on their dosing, and as well as teaching them the signs and symptoms of hypo and hyperthyroidism. Because if they get too much of this medication, it's going to present as hyperthyroidism. If they're not getting enough, the symptoms will remain the same or worse. So it's a constant adjustment. So adverse reactions for levothyroxine. What might you see? If everything's low with hypo, if they get too much of the thyroid, what? Nervousness, yes. Or irritable. The child might get weight gain. No. Weight loss. Because they have weight gain with hypo.
Everything, metabolism is speeding up.
It's speeding up. So think about our heart. Tachycardia, palpitation.
Diarrhea.
Yes. Yeah, everything is speeding up. Tremors, insomnia. You may have trouble sleeping. So the fatigue here is because I don't have enough. But I'm kind of skipping ahead. With hyperthyroidism, the fatigue is because I might be staying up. I can't sleep. So I'm extremely tired. So they both have fatigue, but for different reasons. Okay? So your page, in your Pearson book, page 915 shows like the multi-system effects of hypothyroidism. 915. So hyper, too much, increased thyroid hormone. So low TSH, because the body, that negative feedback, the body senses, hey, you have too much on board. You have too much T3, T4. I'm going to stop stimulating the thyroid hormone. Start stimulating the thyroid gland to produce more. So that's why you have the low TSH. In school, that was so hard for me to grasp. That's why I'm trying to help y'all to remember, because it was like I have this high, but why is this low? But it's like it senses too much on board. So Graves' disease is the most common cause of hyperthyroidism, and it's most often in females. Lucky us. Children too, from 11 to 15. You'll see that more in that age group. So it's autoimmune, so the body is attacking the thyroid hormone and causing it to produce too much. Other causes could be thyroiditis. You can have tumors on the thyroid gland that can cause an oversecretion. And congenital hyperthyroidism, y'all, is temporary and very rare. Usually only occurs in infants whose mothers have Graves' disease. There's a transfer via the placenta of the immunoglobulins, and so it usually disappears by 6 to 12 weeks after birth. So you don't see that coming. 908 in your book shows the multi-system effects of hyperthyroidism. So like we said, think about these symptoms being associated with hyperactivity of the sympathetic nervous system. So, things you see are going to be a result of that: restlessness, nervousness, tachycardia, hypertension, increased appetite, tremors, heat intolerance. So they're always going to be hot. Their metabolism, their energy is accelerated. Very important. So children may present as having ADHD or being hyperactive. And so they may be undergoing evaluation for that, but they have a problem with their thyroid. So pay close attention to those individuals too, because it may not always be ADHD. So these children may have problems in school, can't concentrate, can't sit still, they're not sleeping. So just like with hypothyroidism, there's a serious complication of hyperthyroidism. Anybody know what it's called? Huh? Yes, it's the storm. It's thyroid. Mm-hmm. So that's a life-threatening emergency where the thyroid hormones are extremely elevated and it requires immediate intervention and hospitalization. Okay? Very acute onset of severe irritability. They may be extremely anxious, nausea, vomiting, hyperthermia, diaphoresis, tremors, and palpitations. This could rapidly progress to delirium, psychosis, coma, and then death. Condition is often precipitated by either acute infection, manipulation of the thyroid gland, so they may be undergoing a thyroidectomy, trauma or abrupt discontinuation of their anti-thyroid medication. So they just stopped it. Treatment involves anti-thyroid drugs and also beta blockers, specifically propranolol. And then they need fluids, replace electrolytes, and those things like that. But they are going to get anti-thyroid hormones and propranolol. So these two pictures are classic symptoms of hyperthyroidism, most specifically Graves' disease. So anybody know what that condition is called with the eyes, the first?
The X.
What? They are bulging. You know what it's called? Exophthalmos. It's a mouthful. Yes.
On a commercial with the lady who had that, who always talk about medicine with the big dog sunglasses, and they just say bulging eyes.
They should do, but it's medical term is exophthalmos. Exophthalmos. So it's EXOPHTHALMOS. So the bulging protrusion of the eyelids is due to edema and fat deposits that come behind the eyes, and then the inflammation of the extraocular muscles of the eyes. So it forces the eyeballs out. Okay? So you may imagine that these patients are at increased risk of corneal dryness, like their eyes are going to be extremely dry, irritation, and even infection, and possible ulcerations of the eyes. Because they don't have the eyelids to protect them, and then it's constant drying out. So as a nurse, you would teach them to protect their eye for any type of injury. They can wear tinted glasses or even eye shields. They may use artificial eye drops for moisture, or cool compresses to relieve that irritation from the eye drying. This can get so bad, y'all, that they can't close their eyes. So they may need to either, I've never seen it that extreme, but the possibility, take their eyes shut at night when they're asleep. I haven't met anybody like that, but. And they should always report any eye pain or visual changes. Okay? Then the second picture, that's the throat. What's it showing y'all? Oh, Gordon. Yeah. So sometimes the thyroid hormone gland can get 2 to 3 times its size. All right, so as the nurse, we're going to get comprehensive history and physical. We're looking at blood pressure, heart rate, height and weight, activity level, level of fatigue. Again, paying special attention to those children being evaluated for ADHD or school behavioral disorders. Obtain, if you have a female, you want to know about their menstrual cycle because it may be irregular with hyperthyroidism. Essentially, what we want to do is stop the thyroid from making the oversecretion of the thyroid hormones, right? So we can do that with medications. We can do it with radiation or surgery. Medications are usually our first line of treatment. And so you see you have listed there 2 anti-thyroid hormones, methimazole and PTU. Our first choice is methimazole, especially in our children, in our pediatric population, because PTU is associated with liver disease in that population. So we want to use methimazole. But the problem with these 2 medications is compliance. So it's not always the best option if they're not taking it. If they're not going to take the medicine, then it does no good. So then that's when we go into maybe surgery or radiation. Surgery, although it has its risks, hemorrhage, what else can result because of surgery? Think about where the thyroid gland is and what it produces.
Parathyroid disease.
Yes. Yes. And also there can be damage to the laryngeal nerve. Mm-hmm. Well, they're going to have us, you're right, hoarseness would be a problem. Sore throat, not so much. I mean, you expect to be sore, but yes, hoarseness would be definitely be a problem. And I said hemorrhage, okay. And then severe hypocalcemia, because we said what the thyroid gland does. And then, as you stated before, sometimes they have to take the parathyroid with it. And so that puts them at risk for hypoglycemia too. Hypocalcemia. So the preferred treatment for pediatrics, although surgery has its risk, it is surgery because radiation is more harmful in that group, okay? So before surgery, they may be given anti-thyroid medications to get the thyroid like in a, what they call EU thyroid state. And this is just so you don't prevent thyroid storm. So they may continue or even up the dosage of that medication. So they have the surgery. What's some things that should be considered in our post-op care? They had a thyroidectomy. They come back to your floor. And you're taking care of them. Head of the bed, what should be the degree?
30?
Yes, 30. What else should we have at the bedside? Suction and what else? A trachea. A trachea. We should also have IV calcium gluconate readily available. Because hypocalcemia can cause muscle spasms. And what is this? A muscle, right? So the airway can quickly close up. That's why the trach should be at the bedside. So trach suction, head of bed, and IV calcium gluconate. Monitor for hoarseness because that's going to be an indication that there's damage to the laryngeal nerve. If your patient starts to exhibit symptoms, elevated temperature, tachycardia, they're nervous, they're confused, do we have a problem? What are those signs and symptoms? So they got their thyroid removed, you're on the right track. And all of a sudden, acutely confused, hypertension, tachycardia, tremor, that's the storm, thyroid storm. So that's that serious complication that we were talking about. So not only also with hypocalcemia, so you'll have muscle spasms, but it also can cause tetany, paresthesias, and arrhythmias too. Y'all remember the Chavostick sign? Of course, so the kind of is when you tap the cheek and then you have facial twitching. That's a sign of hypocalcemia. Trousseau's, you may be getting a blood pressure. And what happens? Yes. Show them again. Yep. So that's called carpal spasms that occur. So you taking care of your patient, you're doing your vital sign check, and you see that happening. You have a problem. Okay, that's an emergency. All right. So education for these patients. Make sure they're complying with their meds. Again, know the signs and symptoms of hypo and hyperthyroidism, and they should wear a medical alert bracelet. So diet with hyperthyroidism, they're going to have an increased metabolic demand, so they are going to need more calories. We want to avoid fatigue. They're already overstimulated, so we allow periods of rest. We keep the environment cool, because they have that heat intolerance. We want to prevent overheating. Emotional support. So body image disturbance. If they have that ophthalmos or this big goiter, or they're excessively perspiring, always sweating. They have this tremor or fine hair loss. And that's just a picture putting it on. Questions, hypothyroidism? All right, last but not least, adrenal disorders. So, brief H&P. Adrenal glands are these small glands that sit on both kidneys, okay, on the top of each kidney. They secrete hormones that we cannot live without, okay? They're broken down to three main groups: glucocorticoids, mineralocorticoids, and androgens, which are sex hormones. The main glucocorticoid is cortisol, okay? This helps how our body responds to stress, how we fight infection, how we regulate our blood sugar, our glucose, maintain our blood pressure, and regulate metabolism. The main mineralocorticoid is aldosterone. It regulates how the body It regulates the body's sodium and potassium levels, right? So therefore, it impacts our blood volume, which is our blood pressure. And then androgens are sex hormones. So that's reproductive health. That's how our body reproduces, development and puberty. Alterations in either of these hormones can produce significant dysfunction. So think about it. If you have too much production of these hormones, that's Cushing. You have a cushion of hormones. That may help y'all. Too little production is Addison's. You have to add. You don't have it. So that'll kind of help you to know what you should be looking for, what that patient might look like, what the clinical manifestations, if you think about it like that. I hope it helps. So Cushing syndrome. like we said, it's an excess of the adrenal hormone, okay? It can be external or internal etiology. So externally, what would that be? What's some examples of that? I have too much steroids. Well, what would be a cause? I'm thinking like, what would cause that? Yes. So that would be, she said, someone who's on long-term steroid, your transplant patients, asthma, COPD, I'm trying to think of lupus, rheumatoid arthritis. So those are some external causes, okay? It's exposure to exogenous steroids. So we're giving these patients steroids. Internal etiology is when there's excessive production of endogenous cortisol. So that's either from a tumor in the pituitary gland or a tumor on the adrenal gland. That's it. So a tumor, either on the pituitary gland or the adrenal gland, will cause more production internally. So what are these patients going to look like? Think about it. If I have too much glucocorticoid or cortisol, I have too much cortisol. What does too much prednisone do? Look at this picture. So buffalo hump. So they have that excessive rounding of the face, excessive fat right here. Then they have that moon face. Okay. When you take steroids, does it affect your glucose in any kind of way?
Mm-hmm.
Yes.
What does it do?
Right.
So you're gonna see hyperglycemia. Steroids also suppress your immune system, right? Immunosuppressant. Thin skin, they easily bruise. Poor wound healing. All that sound like your steroids, right? If I have excessive, and I'm trying to get y'all to break it down like each hormone. So that's excessive cortisol. If I have excessive aldosterone, so that means I have too much what? So we said aldosterone controls sodium and water, how your body holds on to that or releases it. I have too much, so I want to have too much sodium on board, too much water. But also that controls my blood volume too, right? So hypertension. Yep, hypertension. Weight gain. Anytime you have too much sodium and too much water, how is the body going to compensate? Which electrolyte is going to be low? Potassium. So these patients will be hypokalemic, but hypernatremic. Because that's how your body compensates. If I have too much sex hormones, that may present as hirsutism, which is that excessive hair growth in uncommon places. So females, we may get the facial hair, mustache, beards, or it may even be on our chest and our back. Delayed puberty or menstrual periods, acne. For guys, they might have the excessive breast tissue, the gynecomastia, or testicular atrophy. So hyperglycemia, hypernatremia, hypokalemia. And all of those can be life-threatening. So diagnosis is made off of general appearance, so the physical appearance, but also there's some tests. So one is called dexamethasone suppression test. What happens is they give you, the patient is given an IV dose of dexamethasone, which is cortisol-like, right? And then the cortisol levels are checked in the AM. Normally, having this high dose, your body should respond with less cortisol. Because it senses I have cortisol on board, I need to make this. But with Cushing's, I have an excess production, so I don't sense that. So that means my cortisol levels are going to be elevated. They also do this nighttime salivary cortisol levels, testing those. So like even at nighttime, your levels should be low. Okay, cortisol should be low. But they either collect drool or saliva on a pad and test it, and it still remains elevated. And then just to reiterate, your chem panels, they're going to show those electrolyte disturbances. Your 24-hour urine will have elevated free cortisol. And then you can get a CT or MRI and look for tumors. That may be the cause. So our management is going to be dependent on the clinical case. So if they have Cushing's because it's too much exogenous cortisol, how we fix that? She said stop giving it, so they may not be able to DC, but maybe we taper their dose. Yes. So if it's because they're getting too much corticosteroid therapy, you may be able to. It just depends on why they take it. So the medication can be DC'd or dosage altered. But if that's not the case, then and it's tumors, it's surgery. Treatment is surgery. And what they do is it's called a transsphenoidal resection of the pituitary gland. So they make an incision, your upper lip and nose, and go that way to remove the tumor. So these patients, you want to monitor after surgery so the pituitary gland, manipulation of that or excessive secretion of ADH, or if it's not, it can cause diabetes insipidus because you're manipulating that pituitary gland. So one thing we want to watch is the urinary output. These patients are just dumping urine. That's a complication. Also, because of where the pituitary gland is, we're concerned about meningitis as a possible complication of this surgery. When they come back, they'll have this bandage, a mustache bandage. And so we want to monitor that. If the patient says, my drainage kind of tastes sweet, that's a problem. That's CSF fluid leaking. These patients, too, should avoid like that increased intracranial pressure. So as much as possible, minimize coughing, sneezing, bending over, blowing their noses, and things like that, because we don't want to increase that pressure. In severe cases of Cushing's, both adrenal glands have to be removed. In very severe cases, they remove both of the adrenal glands on the top of the kidney. If that's done, these patients require lifelong hormone placement because they don't have the gland at all. Okay? And so they'll be treated with hydrocortisone, and that can be given orally or injectable form too. So just like with any steroid, they have the tendency to cause GI upset, right? So it could be, so you want to give it with food or with and with antacids too, to try to combat that. Injectable form is available. So if the child is throwing up, should we just hold their medicine and say, oh, they don't need it today? Right. You can tell someone so they can switch it to the injectable form. questions on Cushing's? All right. So Addison is caused by adrenal insufficiency. So hyposecretion of those hormones, right? It's rare in childhood. You'll mostly see this between the ages of 30 and 50. You know, John F. Kennedy had that. That's just you won't be tested on that. The most common cause is an autoimmune process, okay? But it can also be caused by tumors, infections, and medication. So now we have deficient glucocorticoids. Not enough. Look at this lady. She's skinny, weight loss, anorexia. Yep. She looks tired, huh? Fatigued. They will also have hyperpigmentation, so this bronze pigmentation. You'll see. Hypoglycemia, less cortisol, less glucose. Deficient aldosterone, hyponatremia. So if my sodium is low, my potassium is going to be high. So she'll have hypotension too. And we know hyperkalemia can cause arrhythmias and EKG changes. That's important. Less sex hormones, low libido. They may have infertility too. So early in this disease process, they may just present with fatigue, some weight loss, GI signs and symptoms. And then initially, as it gets worse, they may have profound fatigue, dehydration, and hypotension. They're going to crave salt too. So they have salt craving. Adrenal crisis is a serious complication for Addison's disease. And it's caused by stressors. It can be like emotional relationship stress too, but also like anything that stresses the body, trauma, surgery, infection can cause someone with Addison's to have a adrenal crisis. So in this crisis, they may have pain in their lower back, abdomen, legs. They may have vomiting. They're going to be dehydrated and have hyperkalemia. So we treat it with aggressive fluid resuscitation. They'll have saline solution that's likely going to have dextrose added to it. IV steroids, IV glucose. They're hospitalized when they're in this crisis. So to prevent this, patients who are with Addison's who may be undergoing a surgery, their dosage of steroids may have to be tripled in times of stress. So they have a planned surgery, or they're being hospitalized for an illness or infection. Their dosage have the increased need. So the dosage may even have to be tripled. So diagnostic test, similar to Cushing's, but it's an ACTH stimulation test. So at first you get a baseline blood draw of your ACTH and cortisol levels. The patient is given IV or artificial ACTH. That should stimulate the adrenal glands to make more cortisol, but it does nothing. Cortisol levels still remain low or undetected. So the body is just not there. They don't have it. Then you get a CBC a chem panel looking for that hyponatremia, hyperkalemia is what you'll see, and then again CT MRI for tumors. So how are we gonna treat? You're going to give what you don't have. That's right. They don't have the steroids, so we're going to give it to them. Very good. So it's going to be replacement with prednisone and meds like prednisone, hydrocortisone if they're deficient in the glucocorticoids. If they don't have aldosterone, there's a medication called fludrocortisone, and it's spelled FLUDROCORTISON.
TISO.
So it's meant to replace aldosterone.
So it's not necessarily they're gonna need both.
No.
Both.
They may or they just may need one.
Okay.
Yep, that's
So
one
one or the
question. Yeah. So minor conditions is just oral supplementation with these and liberal salt intake. But if they have severe disease, they may require IV or IM injections. Well, I should say just monthly injections. Or they can have pellets placed. So pellets will be placed in their body and just have a gradual release of the medication. Lifelong, y'all. They're not going to get off of these meds at all. And they should be educated not to abruptly stop for any cause at all. So oral form has a bitter taste. It can have GI side effects, so give it with food and acids. You're going to have weight gain with this. There's an adverse or side effect. So these patients should change their dietary habits, no additional calories to prevent obesity. And then the parents and the patient should always have someone who knows how to give the IM injection of the steroid. Because if they get into a crisis and they can't give it themselves, or if they're vomiting, having diarrhea, and they're unable to take the oral form, someone else needs to have the education that they're going to be around to know how to give it to them in those emergency situations. Environmental factors, these patients should maintain a low stress environment, and they should always wear a medical alert bracelet. And then, like we said before, emotional support. They're going to be on this for the rest of their lives. And so they need to know, too, when their dose is too much, what they might be experiencing, signs and symptoms, how that might present, or when it's not enough. That's it. Any questions? Yes. Hypo? Uh-huh.
The acquired is weight gain and congenital is for weight gain.
The signs and symptoms?
Both of them are increased weight gain.
Did I have something else?
Yeah, the congenital is for weight gain.
That's why.
Oh.
That's why.
Right, because they're not going to be eaten. That's right. I'm sorry. I misspoke. You're right. So it would be for congenital, because those babies are not, they won't be eaten. But acquired older ones, they are going to have the weight gain. Yes. Sorry about that. Thank you for clarifying. All right, y'all enjoy the rest of your day.
Thank you.
And good luck on the OB Kaplan today.
Yeah.
Okay, for those of you who have it. Don't forget your phone,